Hi, good morning, and thank you for joining us today for this telehealth session. Today's session is brought to you by Now New Mexico Quality Improvement Initiative and focuses on optimizing care for neonates at risk for opiate withdrawal syndrome. Today's session is one of a 12-part curriculum designed to provide you with education and opportunities for case consultations around this focus. And our speaker today is Dr. Heather Pratt-Chavez. She's an associate professor with the Department of Pediatrics and has been with the University of New Mexico School of Medicine since 2010. Welcome, Dr. Pratt-Chavez.
Well, thanks for having me. So today we're going to talk about pharmacologic treatment for infants with neonatal opiate withdrawal syndrome. And I want to come back again to the designation of neonatal opiate withdrawal syndrome and remind everybody that we've talked about this before, that it is similar to neonatal abstinence syndrome. It's just a more precise description of babies who have withdrawal symptoms, specifically from opiate exposure. So it comes under the category of neonatal abstinence syndrome. It's just a more precise description. So you may see neonatal abstinence syndrome used equivalently to this description. So we'll be kind of taking an imaginary case through indications for pharmacologic treatment and how we would start a patient on the medication, which medication we would choose for this patient, how do we start the medicine, escalate it, wean it, and what do we monitor for while the baby is under treatment. So this will be the talk that follows up our last talk about identifying a baby. So we have the three components of care for infants with neonatal opiate withdrawal syndrome. The first is the identification, and then the second is observation and assessment. So now we've reached the third part of treatment for babies with neonatal opiate withdrawal syndrome, and that is the treatment. So we're in the treatment arm of this section. So this would be for providers who are at an institution that is prepared to use medication treatment for babies and how they would do it and monitor. Okay, oh my God, this beautiful baby Rose, so cute. I mean, she is brand new, but her mommy already got her dressed up and took this beautiful picture of her. And so this is our patient for the day. It's gorgeous baby Rose, who is desired and well-loved by her mommy and daddy. We're going to start our care for her one day after she was born. So we know from looking through her records that she is a term baby. Mom's pregnancy was complicated only by maternal substance use disorder. She's on medication-assisted treatment in a treatment program with her providers, where she was, her opiate withdrawal symptoms were controlled with buprenorphine. During her pregnancy, mom's UDMs, or urine drug screens, were only positive for buprenorphine. The baby had an uncomplicated delivery and did not need resuscitation in the delivery room. Since she was born, the family has been together, rooming in, and getting support for breastfeeding and working on skin-to-skin and other routine newborn cares. We also noticed that overnight she has been being scored using the Finnegan tool, because after her initial newborn period, right after the delivery room and then coming to the mother-baby unit, she started to be a little bit fussy, and her team was concerned that she might be having some withdrawal symptoms. So overnight, her team was coaching her on doing non-pharmacologic treatment interventions, which will be a whole presentation in detail about the set of recommendations we'll have for non-pharmacologic interventions. But basically, it's swaddling, reading infant cues, and skin-to-skin contact. So we'll come back to that in a full presentation. So now we're ready to come in and start looking at some more details for baby Rose's care. And one of the handouts that will be that you should have for this talk is a scoring sheet for baby Rose's team overnight. And so taking a look at that, you might notice some features of her scoring sheet that, since she came to the floor and in the past 12 hours, her scores have been trending up. And you may notice that her last 3 scores added up to 26. And also, if you remember from our last talk, we talked about some features on the scoring sheet we feel are very important measures of how well we're doing for the baby, and that would be sleep, and whether she was feeding, and also crying. And those, we noticed right away she was scoring for those 3 categories, especially this morning since we arrived on the unit. So now we go into the room with Mom and baby Rose. What's great is that her provider team overnight had given Mom a copy of the score sheet, so she's been scoring the baby as well. And she is really worried and upset about how high the scores are. And she says that she thinks the baby is having a lot of trouble latching, that initially in the delivery room and right when they got to the floor, the baby was latching well. But now the baby's struggling and seems uncoordinated. And she's also really sad about the possibility of Rose needing medication, and is expressing that she just doesn't want the baby to be suffering, and is tearful at this time. And this is the video we used at the last time, but this is what we see for baby Rose, and might be a presentation of a baby who's scoring around where baby Rose is. So she's crying. She's away from her mommy, so she's in a bassinet. She's having tremors and also some large muscle jerking, but this will really be a feature of tremors. But she also clearly, none of us has to really guess whether the baby is suffering and uncomfortable in that video. We really all know it, and it's we were just talking about how this video is kind of upsetting to watch. It is, because you want to pick up that baby and snuggle them and care for them and make them feel better. So certainly that's what our whole care team feels like we need to do for baby Rose right now, is make her feel better. And so since baby Rose has used up all of her pharmacologic interventions and still is scoring high and is meeting the criteria for a medication, we have to consider which one we're going to use. As part of this project, we're going to recommend an oral morphine protocol, but I wanted to let you know what some other medications were used for babies. Phenobarbital was one that was the first medication used for neonatal opiate withdrawal syndrome, and it was used really with the idea of for its sedating effects for babies, and also because it does look like babies who are having withdrawal, they are at risk for seizures, that this probably helped with seizures. The problem with phenobarbital is that it's not addressing the receptors that are activated and are at a deficit. The mu receptors are the opiate receptors in the brain, and they are overactive when a baby is exposed to a lot of opiates, and then they're what stimulates the withdrawal symptoms for babies. So we're not hitting the right receptors with the phenobarbital to really relieve the withdrawal symptoms. And also, we do know if there are a number of studies that show that there are long-term effects of phenobarbital, that babies who get phenobarbital for seizures have long-term cognitive deficits and an increased risk of cerebral palsy, as well as kids who get phenobarbital for other indications. There is strong evidence of long-term cognitive effects. So it's not a great medicine, when we don't want to have to use. For a long time, we've used methadone, which is an oral medication. It's the same methadone that adults use to control their symptoms. So it has similar safety and effectiveness for babies. It's a loading dose, weight-based protocol. Methadone has a long half-life. We know that for adults, it's somewhere between 12 and 24 hours. So it does take a little while to be able to see the effect of your treatment for this medication. So you might give a baby a dose and then not know if you're controlling their symptoms for 12 or 24 hours. Sometimes it's really the best medication because it is a loading dose. So when you have a baby with severe withdrawal symptoms, sometimes it's nice to give them a nice loading dose and really control their symptoms. An old school one is the tincture of opium, also called paregoric, and don't use that one. No, it's in an alcohol suspension. It's 45% alcohol. So it's like a shot of liquor. And then it's got other weird stuff in it too that's not good. So don't use that one. I don't even know if they have it anymore, but it's always included in the historical treatment. So I always mention it. What's exciting on the horizon, and maybe something even through this project, because it's coming up quick, that we will start using is buprenorphine, which is the medication that we found works really well for adults to help with opiate substance use disorder. It's a mu agonist and antagonist, so it has both. It kind of quiets the empty receptors and then shuts down ones that are open too. So this is pretty exciting. Research is really showing that babies need less treatment, shorter stays when they get the buprenorphine treatment. It's got some issues too. It is in an alcohol suspension as well, and it has to be sublingual. Sorry. So it's a little bit trickier to dose, but this is exciting. Keep it in the back of your mind. We may come around and change our protocol recommendation at some point. So the pharmacologic treatment protocol we're going to recommend through this project, and what we really support all of our providers using, is the oral morphine protocol. And that it should be on your handout that you got today. This is the protocol we use at UNM. It's our UNM guideline. It is based on the MOTHERS trial. Notice that it's score-based, so it is not weight-based. So what's nice about that is that hopefully there's less risk of dosing errors, because we don't have to do any calculations by baby's weight for the dose. And it's also, we can immediately titrate the score based on the baby's clinical presentation. So the MOTHERS trial was a pretty good-sized randomized controlled trial that demonstrated that when pregnant women had their medication-assisted treatment with buprenorphine versus methadone, the babies had less severe clinical presentation of withdrawal. They had shorter stay in the hospital. They needed less medication, and it was just very supportive of pregnant ladies using buprenorphine. But also during that trial, this is the oral morphine protocol that they used, where they had such nice results with shorter hospitalization and needing less treatment. So the morphine protocol that we're talking about as well is one that's really used in most large institutions nationally. It's very well supported. So the advantages of oral morphine, we've kind of talked a little bit about it. It's not weight-based, but what I would like about it in my clinical practice is that it has a short half-life. So it's somewhere around 3 hours, 3 to 6 hours. So we know that we're getting max effect for the baby at about an hour and a half after we give them this dose. So we really know if we've addressed their symptoms well or not. And we can also see if we've overdone it, if they are having some of the side effects from too much of a dose, and we can fix it relatively quickly. So it really allows us to titrate the medication better to baby's symptoms. And then it's also very common. It's inexpensive. Most institutions will have it. There are risks to it. If we give a baby too high of a dose, they can be overly sedated and have poor feeding and have respiratory depression. Again, like all of these treatments and medicines we're talking about, we don't have great evidence that it is a benign medicine for babies' long-term development. We know that it's effective in decreasing their symptoms, but it also is, it does create dependence for the baby. We can't just give them a dose and then stop. We need to wean it off. So it is opiate replacement treatment for withdrawal symptoms. So it's our best medicine that we have right now, but it'd be nice if we could fix everything without using another opiate someday. So the risk of this medication mean that we have to be thinking well in advance if how we're going to handle a baby and the monitoring that they're going to need if we have to start opiate medicine for the baby. Okay, so this is the quote from our UNM hospital guideline, and it's based on the MOTHERS trial. Both of those are cited down at the bottom of this slide, and really that's, I could put that citation on all the slides, but those are the two pieces that I really use for this talk. So notice that we'll give the dose for babies about every 3 to 4 hours. So we try to do it with their feeds, and we don't want to exceed 4 hours between the dosing. If the baby is sleeping, then we can wait till It's about 4 hours between the dosing. That's the formulation that we'll recommend, the 0.04 milligrams per 0.1 milliliter. And so notice there it says score dose for initiation. So the score range are the first numbers there, and then the dose is next to that. So the our little baby, her last score was an 11. So we're going to plan for her to be scoring at the 9 to 12 range. So that will be a 0.04 milligrams per dose, given every 3 hours, with a little wiggle room up to 4 hours if need be. So if she was scoring higher, we would start her at a higher dose. And this is the recommendation for monitoring for babies. So we should hopefully have planned ahead, and we have the baby in a unit where we have the capability of either continuous pulse oximetry monitoring, which is how we do it at UNM, which has advantages and disadvantages, or we have the plan for someone to go in and assess the O2 sat and respiratory rate 30 to 60 minutes after the first dose and after the second dose, and then between 30 and 60 minutes after each dose increase. So right now we're at the initiation phase, so we're planning for someone to go in and check that baby's oxygen saturation respiratory rate 30 to 60 minutes after that first dose, and then again after the second dose. And this is a way we can prevent unrecognized respiratory depression from this medication. So like I said, at UNM we have a lot of these babies are in our ICN3 unit, which is level 2 nursery, where they're on continuous pulse oximetry. They are in an open nursery. It's not rooming in, so that's not great. And so we do feel nice that we can watch the monitor all the time, but it does mean that there's a beeping monitor with lights and flashing information that kind of goes against our non-pharmacologic interventions for these babies. So it's not the best environment. So these are hopefully things that we can plan for well ahead for babies to maximize their comfortable environment, but also their safety at the same time. Okay, so back to little Miss Rose. We've ordered the 0.04 milligrams of oral morphine every 3 hours. We're going to continue to work on her non-pharmacologic cares, doing some specific interventions for the baby, because we noticed that she really likes to be swaddled tightly. She likes to feel that she's secure. So we're coaching the dad on how to do effective swaddling, which is an important dad skill for everybody. We're going to continue scoring baby. We don't just start the medicine and then stop monitoring. Scoring is ongoing scoring is how we know that we are doing effective treatment for the baby, and also know when we can wean the baby. This is a very important time to have a discussion with the mom again about what the duration of hospitalization for her baby potentially could be at this point. And notice I said again, because ideally we have been talking with the family and the parents from early in the pregnancy about the possibility of a long hospitalization for their neonate, and that the hospitalization comes in 2 components. The first is the observation and identification piece, which is a 96-hour hospitalization. If the baby needs treatment, that is a separate longer hospitalization. So ideally, the family has been aware of this from the beginning, and we've talked with them during that whole 96 hours when we're observing the baby until we know she needed treatment. So hopefully this is not new information for the family, but it's very important. This is a question that the family wants to know the answer to multiple times a day, every day, is how long do we have to be here, and how long will the baby need treatment? So it's a fine thing to repeat over and every time. Just plan on that being part of your ongoing discussion with the family, and letting them know that what we're going to do is we're going to keep Rose in the hospital as long as she tells us she needs us. So she needs us right now. She needs medicine and she needs monitoring. So as soon as she doesn't need us anymore, we want her to go home and be with parents. So unfortunately, 4 hours later, we go back in and see baby Rose again. And if you will, change that score is 11. That was an error on my slide that I just noticed. So the score is 11, if not 13. again, she's scoring for crying, and she didn't sleep this whole time since we gave her that first dose of medication. So clearly we're not controlling her symptoms. She looks almost the same as when we first saw her. She's maybe a little bit less jittery, a little slightly more calm, but she's crying and difficult to console. So let's take a look at what we do for the in the escalation protocol at this point. So again, it's score-based. So we're really trying to look at the clinical picture for the baby, and not just we're using the score as the indication for what the dose should be. So if the scores are between 0 to 8, then we're not going to change any dose. If it's the scores are 9 to 12, and hers was an 11, remember I said that if the slide is an error, so it's an 11. So that puts her in the second category of increasing the dose by 0.02. And we recommend too that if you're thinking that the baby needs escalation, that it is fine to do multiple scores, have other providers come in, have the family score the baby, have everyone agree that this score really is going up and that we do need to escalate. And to make sure, we recommend to score before feeds, but sometimes the baby's starving and is wild before they feed, and then they're fine after a feed, and so that is fine too. Really, we have this protocol as a recommendation. It's not a strict algorithm. So work as a team and do cluster cares with your baby and with your family too. So we order her next dose after this. We're going to, reminding that we started her at 0.04. We're going to increase the dose by 0.02 milligrams. So her next dose is going to be ordered at 0.06 milligrams, and we're going to do that ordered every 3 hours. At her next set of cares, her score is improved. It's now 5, and mom reports that after that dose, she was able to sleep for about 2.5 hours, which is the longest time that she slept. And really, that's one of our most important measures that we look at, is that the babies are able to sleep comfortably. She's still learning how to breastfeed, and mom is a first-time breastfeeder, so they're working on all those interventions together to try to breastfeed. So these are some more details about how we monitor babies through their treatment. The timing of scoring, again, we talk about that it be every 3 hours before feeds, but sometimes that's a time when a baby is really escalated. So it's okay to reassess. So right after a feed or within an hour, it's all right to just continue to assess with the family and not hold to a very strict every 3 hour assessment for babies. We can modify as needed by the baby and the family. Reminders that we'll follow the oxygen saturation and respiratory rate after the first 2 doses and after any escalation. Okay, so now she feels better and she's back to her cute self. This baby in this picture is a newborn who's in the quiet alert state, where she is resting peacefully. She has her eyes open. She is able to take in all the stimulus that's around her with the lights and the sounds and new smells, and it's not escalating her. She is able to take in all of this new information that's new to her whole nervous system and tolerate it without it making her upset or making her shut down and just fall asleep. So this is our goal. If you see your baby in this quiet alert state, we know we're doing a good job managing her symptoms. Babies who have opiate withdrawal symptoms will cycle quickly through their states of awareness. So they'll spend only short periods in quiet alert state before possibly all that stimulus is intolerable for them, and then they'll cycle into crying, or they'll go right down into sort of a falling into a deep sleep where they'll have myoclonic jerking, and they'll only be able to stay in their sleep cycle for a shorter period of time. So they'll have all of the normal newborn states of awareness, they just cycle quickly through them. So we know if we are getting a baby to be comfortable for longer periods of time in this quiet alert state, we're doing a good job. And we all feel, I don't think we have great evidence for it, but we all have this feeling that when a baby is in this state, that we are really maximizing their potential for their neurologic development to be good. If they can't stay in these states of sleep and quiet alert, we're worried that we're impairing their neurologic development. And we can do it. Okay, so now we've got her comfortable. We start to think about when can we take her off this medicine, and the family's asking about how we do the weaning. So we want baby Rose to stay stable on her current dose for 48 hours before we start weaning. And then we will wean by 0.02 milligrams about every day. If we find that she needs a little bit quicker weaning, like she's sedated, we certainly can go a little faster, but it's about daily. So when we come in for rounds, we usually will make that change for the baby. So we want her scores to be ranging from 0 to 8. And if her score is 9 to 12 then, or greater, then of course we don't do the wean. If it's greater too, we could also consider escalation. In our institution, there is certainly, we see that there is variability in the levels of infant scoring between night and day shifts, between different providers, between different units. And so there is certainly babies at night sometimes will have higher scores. There is a certain time of day, we call it the witching hour, it's like 4 to midnight-ish, where I think all the babies in the whole world kind of go into a little rebellion and are rotten. They cry a lot and are difficult to soothe. And I always imagine someone in a satellite above Earth as it goes around and just hearing all the babies below going, like at 4 p.m. around the Earth, you know. So I think it's also really helpful when we're monitoring babies to look at large patterns of scoring. Like, is the baby having trouble at night? Is the baby having more trouble when mom can't be with the baby? Is there a certain one person who's scoring who scores higher than all the other people? And remember that the score is a subjective evaluation of the baby's symptoms, and that sometimes we all have to collaborate and talk about the whole picture for a baby. So the Finnegan tool is a great tool, but it is subjective and needs to be taken in the whole picture of the baby's clinical care. And that's why I also think it's really powerful and important to have the parents be empowered to do the scoring and have the scoring tool with them. Because if we wean because the baby scored 112 because she's getting a diaper rash and got really cranky after a diaper change, and it was also 5 p.m., and then that maybe not be that's not the indication of withdrawal symptoms being bad. It's a baby who's not having a great moment. We also noticed that if for some reason mom can't be with baby, and scores are higher, we should be careful that we're not scoring and giving babies medication when they're lonely, and that maybe they need cuddling and non-pharmacologic care if mommy can't be with them. So while this is an excellent protocol, we need to keep all those features in mind. So back to baby Rose, we after the 48 hours stable on that dose of 0.06, we start weaning her on day 4 of life. So this family has been in the hospital for maybe 2 days of mom's labor and delivery, and now 4 days postpartum. So we're getting to be almost a week of hospitalization for this family for theoretically for just a baby's birth. So it's very stressful. And this is when you get to about a week of hospitalization for a family, it's a great time to check in with them and make sure that you kind of go through everything in their social history again. Are they doing okay? Communicating with each other? Do they have some support? Do they have food for everybody? Are there other children? How are they getting to school? Who's caring for them? And making sure we're not missing anything else that's going on for a family. Because a week in the hospital is extremely demanding. So at day 4 of life, we noticed baby Rose. Now she's only getting up to an 8 when she's cranky. Mom is really tuning into her signals and is able to soothe her well with non-pharmacologic interventions. And so we're going to start weaning her by 0.02 milligrams each day, and she hasn't needed an escalation. She's only gotten up to an 8. So it takes her a full 8 days before we get her off the medication, and we observed her for 24 hours after her last dose. We observe babies for 24 to 48 hours after their last dose of oral morphine to ensure that they don't have rebound symptoms or any complications after the wean. And there's some variability in that length of time, but we recommend usually 48 hours is the best. Because baby Rose had an uncomplicated weaning, 24 to 36 hours is adequate for her. There she is again. I just wanted to put that up because it's so cute, really. So there's our goal for this little baby, is even though she had opiate exposure and experienced neonatal opiate withdrawal, we were able to use medication to carry her through her acute withdrawal symptoms using our oral morphine protocol and the Finnegan tool as a evaluation of our treatment. And so this was all that I wanted to present in this talk, because it's a lot of protocol data and really one that I want you to take back to your institution and start practicing with your infants, and then coming in for consultation and help if you have questions. So do you guys have any questions about this information today?
I have a question.
Yeah.
So today's scenario, is that typical, that it's a fairly logical process and it's pretty smooth? I mean, considering what situation you're in, is managing, it seemed fairly
a little routine, right?
Right.
Like we did escalate her in the beginning.
Mm-hmm.
We had to adjust in the beginning, but then we were able to wean her rapidly down. And that scenario where the mom is maintained on buprenorphine and the baby only needs about a week or so of hospitalization is exactly what we're seeing, and that's consistent with what they saw in the mother's trial. So we know that if we can help mommies be on buprenorphine, that we do have a fairly easy, uncomplicated weaning process for babies, especially in that scenario that we talked about for baby Rose, where they have rooming in and breastfeeding support and non-pharmacologic support. So that's the ideal, right? That is very common for what we're seeing. So yes, that's how we'd like it to roll. But in practice, there are always variabilities. Maybe if mom has polysubstance exposure, that complicates the picture. If the baby has a different physiology and processes medication slowly or more quickly than mom, then it is complicated. But it's routine enough that really this protocol is very good. It's very effective.
That's great news.
Yes. So it's really good. So if we can do it, we've got some optimistic outcomes for these babies in their hospitalization. Yeah,
that's great.
That's cool.
Any other questions? Well, thank you so much for joining us today. Were there any other final comments you wanted to?
I was thinking about when you were asking me about is this common, really I think that at UNM in my ICN3 nursery, we see longer hospitalizations routinely because babies we're not able to do rooming in that setting. I also have the more complicated withdrawal circumstances where there's polysubstance exposure or other medical issues for these babies, and so their hospitalizations are longer. But still, we try to do those non-pharmacologic interventions and really help those babies. So that's why I had in that one slide to discuss that the hospitalization may be up to 3 weeks, because baby Rose did great, and she is typical for that scenario, but every baby's different, and sometimes it takes them a long time to really be ready to go home. So,
wow. Well, thank you for taking the time to join us today, and thank you for all the important work that you do.
Okay, thanks so much for having me, and I'm excited about this project, so thank you.
Thanks. And thanks everyone for joining us.